a health educationalist. We will have a pre-conference workshop where we're going to workshop it through so that we actually have a workshop format how people can use the enabling factors. And Professor Hugo, you will be there. Begg, our QI lady.
All right, good morning, everybody.
Good morning.
So, although we're presenting this morning and then again this afternoon in terms of the three activities, I think we just want to remind you that actually we're trying to really work this together as an integrated approach. So hopefully you'll see some of the similarities emerging out of the QI work, as you've just heard in the decentralized learning. But actually we're working together and often with the same people. And in fact, it was fantastic a couple of, in early December or late November, to have a pharmacist who'd experienced both work through operational research and through QI, really seeing how this all interfaces and integrates. So that's just a quick reminder that although we're presenting it, it's just that it's easier for us to categorize and present it, but we are actually working in concert. So the next slide just quickly reminds us that it's just a quick heads up as to, so what are we doing for QI? Next slide tells us that we are working to improve the quality of HIV treatment and care. And that's actually the whole project's aim, right? So we're doing that. We're doing through a number of areas in terms of building and strengthening capacity for quality improvement processes. So as many of you will say, well, DSPs have been doing that for a long time. So South to South, you'll all remember, FPD, TB HIV care now. So what's different with Succeed? Well, I think one of the differences is that most of the DSPs are working at clinician-patient interface. And we're actually working at a higher level, at a manager level, just because we actually realize that leadership and governance and management is one of the key aspects for sustaining anything that happens in the workplace, whether it's at a facility level, sub-district or district level. So I'm going to go through the more details, so don't worry about all the writing. We don't expect you to read it, but it is there when you get it. So this, Voyelle were presented earlier. You can see that all of our outcomes are on here. The red are those specifically related to QI. So we start off saying we would need to build capacity. Now, there has already been some capacity building in the province, and particularly in the two districts that we're working in. But we have needed to do some more foundational work in that. So to increase key health professionals' knowledge in QIP, but also in data. Did you hear us say QI and data? So it was interesting right up front when the DIP process. So all of you remember the DIP process? Have you heard about the DIP process more recently? Not really. Okay, we'll tell you about that this afternoon, about what's happened to the DIP process. But in the DIP process, what happened was we realized very quickly that the data in general is actually relatively poor. Would we all agree with that?
Yes.
Okay, so we can't trust the data to go, this is exactly where our problem is. And part of the problem with QI is that we can't do QI without data. Do you all agree? We need to know where we start. We need to know how to track ourselves along, and then we need to know whether we've improved at the end. So actually we can't do QI without data. And in order to improve data, we can use QI techniques and methodology. So it actually fits together very nicely as two sides of a coin. So we're actually looking at improving capacity development in both QI methodologies as well as data quality and use. We've specifically spoken not just about improving data quality, but we strongly believe that when people start using their data, the quality will improve. All right, so it's not just about kind of focusing on let's improve data quality and it becomes like a side project. If you as clinicians, if you as facility managers, if you as district managers, sub-district managers use your data, it will improve because you will be frustrated by the poor quality and you will make a plan to improve it. We just need to give you some skills as to where to look and how to do that. But obviously building capacity, which we know has already happened in this province and in many other provinces, you have to, that's only the start, right? We can't end there. We've actually got to change practice. So we need to start seeing changed practice in the way that we do things clinically with our patients in HIV. We need to see it in our data and use of data for decision making, that we don't make decisions on gut feel, but we actually use the data that's there for us to use. And then, of course, we're hoping that that will then impact on outcomes and improve outcomes. Thanks. So why are we doing this? Next one. We all know this one, right? 90-90-90. So we all know that we want 90% diagnosis, 90% on treatment, and 90% virally suppressed. Next. But of course the challenge is that we do end up, the risk of these is that we can focus just on the targets, right? So we end up only focused on the 90%. And if we don't hit the 90%, then we go and hone in on that little bitty. Of course, the reality is, just keep going, is that, that's perfect, is that we actually mustn't forget why we have targets. The 90-90-90 is to stop illness, right? Is to detect illness in order to treat illness, in order to cure or prevent death, and then stop the epidemic. So we need to be seeing our 90-90-90 not as individual 90 targets, but as a whole. Next slide. As the whole cascade, all right? That we start with who's the population in need, do they have access? Remember that our 90-90-90 doesn't actually show us the access. All right, so we've got to start with the pre-90. Do 90% of our population in need actually have access to care? So that's not yet in our 90. Then are we preventing infections? Are we finding the cases? Are we linking them to care? Are we getting them to care? Are we retaining them in care? We know that that's a huge problem for all of us. And then are we actually making the outcome difference? So so this is the why. And we're going to show you how we've been looking at this through Succeed. Next. Where do we do this? Next is, Riel was just showing you, and I've reminded you that it's on the entire learning platform. So the reason for this is actually, we're going to talk about it a bit later, is about creating sustainability. So we want to create a culture of learning. This isn't about Succeed. In fact, we don't want you to even remember Succeed. We want you just to be doing the stuff that you've learned to do. So none of us actually are worried whether you remember that this was Succeed or APC or UCT or Stellenbosch or anything like that. If you're doing the techniques, that's actually all that is important, is that we create a culture of learning in the district platform. Next. So as Boyelba pointed out, we're looking at a referral cluster. One of the challenges, I'm looking at ages around the room. Who of you, there are some of us, who worked in the health system before the districts? Okay, so we remember regions and all the funny quickies and all the different health systems, right? Okay, so there was this wonderful ideal. Okay, the rest of us who did put up our hands aren't going to look at all of you who didn't put up your hands because you're all very young. The point is that when we created this beautiful ideal system of district health system, which was intended to improve access, it was part of all the way from the ANC health plan, the white paper on transformation of the public service, etc., all the way through, this was the ideal that we would have these hub and spoke. One of the things that we've done, which I suspect is going to be part of the reorganization now, is that we separated our hub and spoke in terms of reporting lines. So we separate the district hospital, refers to the referral hospital, but in fact they report to the district, right? And the CHCs and PHC clinics report to sub-district. Okay, so now when we try to sort out our referral pathways and our issues that aren't working within our sub-district, you can see that the sub-district doesn't necessarily all refer to the same district hospital, right? We know that because of geographic boundaries. So you have a mountain or you have a road, okay? So people move differently. So we're not looking, and in fact that's where we've broken down a little bit of our referral pathway and integration of our services between levels of care, is that we have these different reporting lines. So what we try to do in this project is look at this referral cluster instead of sub-district. Does that make sense? So we are engaging at the referral cluster level, saying let's look at the district hospital as the hub, and then these folks of all the referral clinics. So that's why we're not working with all of the clinics in a particular sub-district. We're working with those that refer to the particular hospital. So Madweleni and all of its referral clinics and CHC. All Saints and all of its referral clinics and CHC, which might not be all of the clinics in the sub-district. Does that make sense? Okay, next. All right, again, how do we do this? Next. So the first is that we make sure that we use the data to identify our need. Not what's in our head, not what's in our gut, but we actually use the data. Next. So we started off saying, let's look across the cascade and take from the DIP process, instead of 48 indicators, just take 12 right across the cascade. Next. And so we start. So we're starting at the tail end. So this is looking at, we've done this across each of the sub-districts, but we're just looking at the pattern. So this is from all the way from 2014 to 2016, because as you know, we are behind, in terms of getting viral loads. So what do you see in the picture? you're not going to see figures, I can promise, and you're not going to read the font size, but what just give you the impression that you're looking at in the picture? There's quite a lot of red, but there's also quite a lot of green. Okay, so we're looking at viral load suppressed, right? So it doesn't look great, but it doesn't look awful, right? Okay, next.
But the red is getting more.
But the red is getting more. And now this is even more worrying because now we go one step back in the system. So we can see that we are suppressing some patients, but in fact it's getting a bit worse. So the red is getting more, but what's happening in this one, or viral loads done, is the greens are getting a little bit more, right? So the reds look horrendous. So in terms of targets, we are not doing enough viral loads. So what the previous slide showed us is that those patients who come anyway, despite the system, generally those are compliant patients, they're taking their medication, they're going to be compliant, they're going to be suppressed, right? So actually this is showing us that despite our health system, our compliant patients still manage to be suppressed. But the parts where we should be acting, we must make sure we do enough viral loads so that we can then track whether we are properly suppressing our patients or not. We're going to go further back the cascade. So we started on the end of the cascade. Okay. So what we've done for each facility is we've taken the data off DHIS, off tier, and we've started having a look at these high burden facilities. Okay. And we're looking particularly, one of the things that has been missed with other DSPs because they haven't worked at district hospital level is they haven't seen the interrelationship between hospital and its gateway clinic. And we've seen that as a very strong, very important connection is between the district hospital and its gateway clinic on its premises. We've been in the early days of us working where the gateway clinic and the hospital actually didn't even communicate to each other. And in Butterworth's case, it's how far away? I wouldn't even say it's 100. You can go from outpatient's door into gateway clinic's door in about 20 meters. All right. So, and that's the same for all of the hospitals and their gateway clinics. So we start to see that, what is the pattern showing us? And we're starting to see some trends. Keep going. Okay, so as we do more, so we're starting to see that we're actually deteriorating. Can you see? So some of these are good and some of these are bad, right? So loss to follow-up is decreasing. What do you think about this factor here? A naught. Do you think that that's true? That we had no follow-up? That we had no loss to follow-up? Absolutely not. So the first thing we do when we look at data is it true? And immediately we're questioning this, right? Okay, it probably was no data submitted, more likely than not, right? Okay, so we start to look at these, and what we're teaching in the quality improvement skills, which I'll get to in a moment, is how do you interpret this run chart? How do you know whether things are getting better or things are getting worse, and where must you act? Next. So similarly here, so things look like viral load completion. You see viral loads done here at Gateway Clinic are looking fantastic. Look how we got all the way up to 70%. But this is likely to be a data problem. It's an outlier, right? So we need to go and look. So what these show us in run charts is they indicators indicate there's a problem. They're not a definition of a problem. They indicate there's a problem. Now we must go look at the data properly. Next. So the important thing is obviously that we need to complete the viral load. So you can see here we had great suppression rates, but if we're not actually testing them, then we can't really pat ourselves on the back and say things are fantastic because our denominator is very small. So we need to make sure that our denominator, that we're actually catching the pool of people that we need to catch. So we can start to see that with intervention, so slowly these viral load rates improved and actually we didn't drop in our suppression rate, which is fantastic. Next. So the first thing we've done is identify where the need is. Now I haven't shown you all the slides, but what we can tell you is that the need is, can you tell me, where's the need in the cascade? Is it at testing? Is it at case detection? Is it at linkage to care? Is it at linkage to treatment? Where is it? Where's our biggest problem? Linkage to care is one, and doing and retaining them. Okay, so that's our biggest problem. And what's contained in our DIP plan? In our DIP of 2 years ago? What were all of our activities for the DIP for Amatole, this is getting? What were those focused on?
They were focusing also on the viral load suppression.
Yeah.
Viral load completion at 6 months.
But most of your activities, 66 of them, okay, we can all remember 66.
Yeah.
Not. We can't remember 66, okay?
Many activities.
Exactly, but most of those were sitting in case detection and prevention, condom distribution, etc. And what did our data show us? That actually we're doing all right. We're not doing fantastically, but we're doing all right. Our problem is somewhere else. So actually, for the Pareto principle, do you remember that, the 80-20? We should put more of our effort where the biggest problem is. We should be putting our effort in. Linkage to care, retention in care, viral loads done. Okay, so that's what this is helping us remember, is that we actually focus on where the need is. Next. So how do we now identify the gaps? So we started off with some assessments, some baseline assessments of QI capability. So we started looking at areas of what's the context for QI? So in other words, is there an enabling environment for QI? So you can see the similarities with decentralized learning. Is there an enabling environment? Can we do it? Have we actually got the competencies and skills to do it? Can we think about it? Have we got some of those critical thinking skills? And then what are the organizational factors, which includes leadership and governance? Okay, next. So what we did was there were a whole bunch of tools we used, which are research. So we did a scoping review to look at what research is there to tell us how we should measure these things. Next. And what we found is improvement happening. So in the 3 sub-districts, we're looking at 15 facilities, only 2. Now remember that we've already had training through HST, South to South, FPD, before we arrived. Only 2 of those facilities had active, documented QI efforts when we arrived. So what we're seeing is not that people don't want to, it's just that it's not sustained. When the nurse mentor is there, holding the hand, then the QIPs happen. When the nurse mentor's not there, it seems like it's a lot of work, it's extra, it's on top of my job, not part of my job, right? So we see that. We also see that there were no formal quality improvement plans. So where there were quality improvement efforts, they weren't articulated in a quality improvement plan. Next. There was awareness. So remember, most of these people have been trained at some point or another, but in fact, it was very varied in terms of people's understanding. Next. We gave critical skills. So even if you don't have a plan, if you were given a problem, do you know what to do with that problem? All right, so that was like a little mini test. And what we found was that only 15% of those who were able to do it. So there were 120 people who did this little test, and only 15%, 18 of them, actually passed. So remember, we've had all this training, but actually when we put the little, and these are the scenarios, so they're not complicated scenarios. One's an HIV scenario and one's a TB scenario. But actually only 15%, not 15% passed. So it says that our QI skills are very superficial. All right, we don't have a deep understanding of them. Next. Okay, and then we also, so given that, but when we said to them, how do you think you're doing? Plot yourself on a scale of, we're doing not so great, we said at the very beginning, or we're doing fantastically, we know what we're doing, everything's fine. People plotted them on the, we know what we're doing, everything's wonderful side. So people think that they're doing wonderfully, but when we actually test them, they're not doing wonderfully, all right? So that is worrying because people don't have insight that they need more help. Next. Okay, so the second thing that we then saw was with data. We noticed that when people were doing QI, or even just tracking their normal things on the clinic, is that many of the graphs, etc., weren't completed. Okay, and when we started to ask a little bit, we got a lot of anecdotal feedback that many professional nurses in particular were uncomfortable with anything to do with numbers, right? Everybody agree? Okay, so now what we saw is this clinician, whether it's a doctor or a nurse, by the way, and data, whether it's an information manager, data capture, we saw this divide. So if we ask the facility manager, what's your total remaining on art? I mean, we don't expect like an exact number, but more or less 190, or more or less 350, or more or less 20, right? Okay, round it off. No idea. You need to go and ask the data capturer. But you're running the clinic, you're running the service, right? Okay. So we realized so we were suspicious that maybe they are very uncomfortable with dealing with numbers. So we ran a numeracy test, okay, on HIV/TB data. So we said, why is this data important? Can you take this data and calculate a percentage, right? So you take a numerator, denominator, make it into a percentage, and then plot it on an X and a Y axis and make a graph. Okay, and then we gave a graph and we said, interpret the graph. What does it mean? And then we said, what are you going to do about it? Okay, so that's all fairly simple, right? Everybody agree? That's what every manager should be doing? Yes? Yes? Okay. All right. So what we found, just go back up one, is that first of all, just back one, is that this, just so that you know, it was even amongst the sub-districts, and job categories we had managers, nurses, information people, so data captures, information officers, information managers, at all levels, sub-district, district, and facility level, and everybody had more than a matric. So we should expect that everybody should be able to calculate a percentage, right? Because everybody's done matric, right? Okay, next. So who passed the test? Little 25-mark test. Only the doctors, and only just. Okay, so not everybody at the doctors passed. But it's quite concerning that even of our information officers who are working with our data all the time did not pass the test. Okay, so even though we have the divide, even then we didn't see that. Next. So now what we said, can you draw a graph? So the reds are no. They're far too big, right? We need to see much more green. Okay, so the data people are not too bad, the doctors are not too bad, nurses and healthcare managers, of whom most healthcare managers are nurses, right?
Yes.
Okay, so we're talking about facility managers. This is really worrying, right?
Yes.
Okay, because a graph is also, by the way, your road to health chart. Okay? Your road to health chart is plotting an X and a Y axis. So if you can't plot a graph, it means you also can't complete a road to health card. Okay. If you can't calculate a percentage, it means you also can't calculate a dose for a pediatric patient's ART. So why are we surprised we're getting some pediatric problems? Next. Can you interpret the graph? Okay, that's even worse. All right, next. So even if you're given the graph, can you interpret it? Can you calculate a percentage? Eek. Next. Can you interpret the scenario? What does it mean? Okay, now this is all part of what we need to be doing for our patients. What does it mean clinically? What does it mean for our... okay, next. Can you calculate a mean, an average? Okay. Can you calculate a median? And what's the difference? Okay, so median, we would have forgiven if median was the worst, it's all right. Okay. But the fact is everything was a bit of a disaster. All right, so we've got a problem. It's no help us sending people to do stuff if they actually can't calculate a percentage. So we've got to start a little bit further back. So now we can start to understand why maybe some of the QI work that was done, some of the training work, which was in run charts, is not happening because actually it was never identified that they actually can't do it. So let's help them do it. Okay, so we need to start a bit further back. So next. So what are we doing to now try and bridge the gap? So I've only presented you two elements. We also did health leadership and management. Okay, and by the way, everybody thinks, so what would you say your performance score is for your district, Mrs. Gede? In terms of, what would you give a score for your district in terms of performance for all facilities and district hospitals? 80%, 60%, 20%, where do you think we are?
Just the overall performance.
Yeah.
I would say.
I'm putting you on the spot, but we all have to learn today.
It's below 50%.
Below 50%. And who's here from Chris Hani, representing the district manager? Mrs. Kieser. Nobody's going to lift their hands up. Oh, Dr. Pradhan. What would you say? What would you say for Chris Hani? A performance, and just an overall performance score. How do you think you're doing?
Around 50.
Okay, all right, so we got that. So let me just tell you that the people who scored themselves about how brilliantly are we doing as managers, okay, they all scored themselves over 80%. Okay, now if our performance is down there, then how can we score ourselves that we are great managers when actually our performance isn't great? So we've got a bit of a lack of insight in terms of where are we sitting versus where is our actual performance. All right, so what are we doing to help? So the first thing is we're starting to build capacity. Remember the three things: build capacity, change practice, improve outcomes. So we're looking at some courses, but very importantly, these courses are certificates of competence. Okay, and by the way, nobody's passed yet because you haven't submitted your assignments. I can't give you a pass mark unless you've submitted things. All right, well, sorry, the M&E you have passed. Most have passed. Most have passed. So we will give you those marks. But in terms of QI, nobody's passed yet because we haven't got those assignments in. I think Madweleni, the MDR team, have passed and they've done brilliantly and they're presenting at IHI. So well done. Okay. But so the point is that unless you put it into practice, the clinical skills are useless. So the course is about exiting with competence. So we make sure that you have to exit with competence. And we've done the 63 students just this year, but we've done 83 overall. Next. Okay, these are some of the projects. So managing loss to follow-up, reducing time to be seen, triage systems, after-hours availability of drugs. And then for all clinics, PhD and CHDs, we're looking at 90% viral load suppression, which means we have to look at viral loads done as well. Okay, because otherwise your viral load suppression is useless. Next. So what are we doing for data and information? So that's on the QI side, and I'm going to go a little bit more into changing practice in a moment. But in terms of data and information, building capacity, we ran the monitoring and evaluation short course at Stellenbosch late last year, and there were 13 bursaries who came down. It's also a certificate of competence, all right? So you had to pass assignments and a little test, and very nice credits. Then information is in 2 weeks' time, and we've got some nominations from your districts for a information and data management for healthcare. So it's not really focused on the kind of principles of M&E, it's literally working with data. An Excel spreadsheet, plotting it, mapping it, putting it into a graph, what does it mean, how do we check the quality, all of that sort of stuff. All right, and using it for decision making. So that's coming up. Next. Once again, a certificate of competence. Then we're also looking at management and leadership, and we have 2 people, this is a big bursary, so we have 2 people currently on who are doing a 2-year program in leadership and management. Next. So we've run 5 courses in total so far with 83 bursary students. This one's coming up now, but you can see that it's all been evenly spread across the sub-districts and across all levels. So it's had clinicians, managers, information people, because I think that what we have seen is this divide between, no, but that's not my job and that's not my job. So managing HR, managing finance, managing data is a line manager's responsibility.
Exactly.
All right. Those other people, HR, finance, and information people are there to support you in your role, but it's actually a line manager's responsibility. Next. So how do we now change practice? So we start with the skills, we now start to change practice. So one of the things is then to sustain these skills is, so one of the scoping review areas of Element showed us that the evidence shows us that the best approach to use in trying to sustain quality improvement is using low-intensity training together with learning collaboratives. All right. And I call the learning collaboratives the Begg breakthrough series approach. And so it's these repeated improvement cycles, or those of you who've done it, PDSA cycles, right? So you do repeated PDSA cycles. You work in a cluster. So remember, we're saying we're working in a cluster. So we're pulling people together so that we're getting hospital and district and facility staff all together and helping them work together. So we're using learning sessions with support in between. So we have support visits where we actually go on site and have a look, and let's look at your data, see what's happening, etc. Okay, next. All right, so where are the gaps in care? So now this is what we do when we're doing the learning collaboratives. Where are the gaps in your facility or in your sub-district? Next. So how are we doing with HIV testing? So we just used, this is in Kolbo, just as an example. So you see everybody gets a chance to have their results shown today. But we're not showing everybody's results for everything. So these are our targets versus our actual. So All Saints Gateway is doing fantastically in testing. So keep this in mind, all right, for the next slide. Eloweni is doing all right. In Kolbo, CHC is not doing great, all right. Or in fact, doing fantastically, sorry. Is you over-testing, which is fantastic. You're testing more than your target, but Kolmanko is not. Next. So now let's see. In Kolbo, remember CHC, were doing more than they needed to. And guess what? They are picking up the HIV cases. That's what we want to do, right? We want to find them so that we can treat them, so that we can prevent, we can treat them early. And guess what? Because you test a lot, you find them. When you don't test them, you don't find them. Next. So you want to get a yield, and the 10% is the target. So we can see that All Saints Hospital and in Kolbo CHC are doing very well in Chris Hani. Next. So now, the new initiation. So we know that just on a year now we've been going with the new policy, which is test and treat. Okay, now test and treat is fantastic for us because it means we've got less chance to lose patients because at the time of testing we can treat instead of waiting for them to come back and then they don't come back. So here is our target for All Saints Gateway. So there's a big gap here over this 3-month period, but maybe our target was unrealistic, right? Okay, or there's something wrong here, right? Okay, either we're really bad or our data's really bad. Do you agree? Or our target's really bad. So it's an indicator that there's a problem. It doesn't tell us what the problem is. It's an indicator there is a problem. We need to go find out. And All Saints Hospital doesn't have a target because they're not supposed to start, but of course they do. So what we find with the hospitals is that they've got funny data sitting on their system because they either don't enter the data on. So Madweleni, okay, has 4 patients, am I right? 4 patients on tier. Okay. Well, they should have some, right? Because they've got staff who might be positive. Okay, but the pharmacy are issuing 20. Okay, pharmacy issuing ART for 20 patients, but we only got 4 on tier. So there's a problem. Okay, we haven't got them on tier. All right, or somebody's selling ARTs somewhere. Okay, so it indicates we have a problem. We need to be finding where the problem is. Okay, next. So let's have a look. So these we've said where our main problems are. Next, okay. Next. So those 2, yes. Yep. Next. Okay, go. Okay, so in test and treat, we've got great intentions. The challenge is that we don't have a system in place to track initiations, so we're not entering them on tier. Tier is our way to measure. It tells us whether we're doing the job that we're meant to be doing. So we need to find a way to make sure that we enter on tier. Next. Are we doing viral loads? Next. Tier reports and our failing patients are referred, but we're not following up that they're seen because our referral network, because we don't talk to each other, we're not checking that our patient is getting to the other side. Okay, next. All right. So I'm going to go very quickly because I'm now over time because I'm very excited about all of this. So where do we start making an improvement? We start looking at those with the individual clinics and we start looking at specific, really easy ways on site. So no fancy tricks, stuff that you can use on site. It might even be as simple as a cardboard box. All right, with a big sign on it saying patients awaiting treatment start. Next. Okay, filing results. So we need to make sure that we file our results, otherwise we don't have them, right? So when we've done work with NHLS, we've often found the results are there, but we just haven't documented them, all right? So we don't know. So one of the things that we're also working with is taking the NHLS data and triangulating it with what's on tier and seeing whether now that's easy enough for every single clinic and facility to do as well. Next. The cohort tool for TB, very helpful to be able to monitor your absolute cohort. I'm not going to go into detail now, but Fresno can answer questions just now. Keep going. Okay, so look what happened here with test and treat post the learning session. Okay, so we can see that the reds are higher than the blues for the most part, but look what happened after the learning session. Can you see that our ART initiations increased? Okay, so it helps. It encourages us when we monitor our own data to say, oh, wow, we're getting it right. Next. Changing practice, we can also see with tests. So this is testing and starting on ART. We can see that we're also doing much better. Next. Okay, so learning sessions, we've had lots. Next. Lots. Next. Lots. Okay, so last 2 slides. So this is all, some of you might recognize your faces. Next. All right, so some of our challenges which are the same challenges that you experience, routine data, finding it. We've had some changes in system, we've gone onto web DHIS, big problems, but we need to fix them. We need to find ways to make sure that we can do it because without data, we don't know whether we're doing better. And the whole point of us doing this is not just to clear the queues, is to actually make sure that we are treating our patients better so they don't come back. As somebody says, we need to turn the tap off. All right, so that's particularly true for Cape Town. All right. So the water is really important that we turn the tap off so that we can save water, save our patients. Okay. Complex, multiple role players, and that's also very tricky for you, right? There's lots of different people working in different spaces, and these are all challenges that you have. So one of the challenges as well is it's not just about the goodwill of the nurse on the ground. If she doesn't have her ART medicines to dispense, then she can't test and treat. All right. So, it's also about the health system aspect. It's also about making sure that our supply chain works, that key vacancies are filled, etc., etc. People are feeling overwhelmed on the ground. Okay, and I'll talk to that a bit later at the National Health Strip. People are feeling overwhelmed, and what we're trying to do is show them very simple tools and techniques to actually overcome some of that feeling of overwhelm. Because remember, if we turn the tap off, we don't feel so overwhelmed either. And I've spoken about this clinician data interface. Thank you very much.
Thank you very much, Karen. One or two quick questions or comments?